Um, so we have Dr. Jose Franco, currently Professor of Medicine and Associate Dean for Educational Improvement at the Medical College of Wisconsin. He received his medical degree, completed a residency in internal medicine, and a fellowship in gastroenterology at Medical College of Wisconsin. In addition, he completed a liver transplant fellowship at the University of Nebraska. Dr. Franco is board certified in gastroenterology as well as transplant pathology. His clinical interests include liver disease, cirrhosis, and liver transplantation. He sees patients at Fairfax Hospital and Children's Hospital of Wisconsin.
Thank you. Everybody here? Good. So thank you for the invitation to talk to you today about non-alcoholic fatty liver disease. And I will very quickly convince you that this is the #1 patient that all of you see in your practices, whether you're a nurse, whether you're a physician, whether you're a dietitian. These patients are the largest percentage of patients seen at this hospital, as well as any other hospital in this country. So I have no financial disclosures relevant to this presentation. Since there is no FDA-approved therapy for non-alcoholic fatty liver disease, everything I talk about, all the medications I will talk about today are off-label. So, what do I hope to accomplish over the next 45 minutes or so? Well, when you walk out, I would love if you could recognize the prevalence and risk factors for non-alcoholic fatty liver disease. What tests are available to diagnose non-alcoholic fatty liver disease? It used to be that it was just liver biopsy. Now we have quite a few options. We used to think it was a benign disease, but really the complications can range from benign all the way to severe. So if you can recognize that spectrum. And then finally we'll talk about some lifestyle changes and therapies that are promising that will help us deal with this condition. So I always like to start off with a simple definition. What is non-alcoholic fatty liver disease? It is the most common cause of abnormal liver tests in the United States. And on a liver biopsy, if you were to have a pathologist look at a liver biopsy, it looks like the patient is abusing alcohol. So it's the same fatty changes that we see when somebody consumes alcohol. And those changes on a biopsy can range from mild all the way to severe. So just some basic pathology. So this is a normal liver here on the left, central vein, and the cells are one cell wide, and this is non-alcoholic fatty liver disease, these triglyceride deposits. So you don't have to be a trained pathologist. If you were to just look and see the diagnosis is quite straightforward. Can you tell whether this is from alcohol or from non-alcoholic causes? No, that's where the detailed history that we all take comes into play. This is just a magnified slide looking at, again, those triglyceride deposits. So the diagnosis on a biopsy is quite easy to make. So how did we get here? So this disease has obviously been around for a long time, but it was actually not described until the early 80s. So the Mayo Clinic has a program where smaller community hospitals that may not have pathology services are able to send slides to be officially read by pathologists at the Mayo Clinic. And they will read your liver biopsy slide on your patients. So back in 1980, Dr. Ludwig, who's a well-known pathologist, looked at 20 biopsies that were sent from outside of the Mayo system, and he read them all as consistent with alcoholic hepatitis. Pretty straightforward. However, when the reports went back to the referring physicians, none of those 20 patients actually consumed alcohol. In fact, some of them were in nursing homes, never had access to alcohol. One of the things that they had in common is that they were all female, they tended to be obese, and have diabetes. So that was the initial description, that this is a disease that affects women who struggle with their weight, and type 2 diabetes. And then over time it's changed. The name has changed. So we've gone through a variety of names before ending on this last one, non-alcoholic fatty liver disease. But prior to this, all of these other terms were used and they no longer are commonly used. How common is it? If you walk on the streets of America and take 100 patients off the street, approximately 25% of them will have non-alcoholic fatty liver disease. 1/4 of the US population has non-alcoholic fatty liver disease. In fact, we worry about hepatitis C, we worry about alcohol, hemochromatosis, which is iron overload, hepatitis B. All of those added together do not even come close to the staggering numbers of non-alcoholic fatty liver disease. This larger bar, the orange one, represents patients who have simple fat in their liver. And we'll talk about that. That's called steatosis. This second bar, non-alcoholic steatohepatitis, frequently abbreviated as NASH, are patients who have fat plus inflammation. Fat plus inflammation is the aggressive form of this. Fat by itself typically does not cause major abnormalities. It is the non-alcoholic steatohepatitis. Is everyone affected the same? Absolutely not. So you can see that Hispanics, up to 45% of Hispanics have non-alcoholic fatty liver disease, and you can see actually Caucasian patients, and then African Americans or blacks much lower. Which is interesting because the African American population tends to struggle more with diabetes. Diabetes mellitus is more prevalent in African Americans, and we know that that's one of the risk factors. But clearly there's other factors that come into play. So this is a common disease that affects our patients. So whenever I talk to our residents, and our medical students, I say, if I were to walk through the wards of Freighter Hospital, that's where I see patients, I'm going to venture that 50% or more of those patients hospitalized have non-alcoholic fatty liver disease. So, this is the progression of the disease. So patients get steatosis, simple fatty liver. Approximately 10% will develop the more aggressive form, the NASH. NASH means they have inflammation, steatosis is just fat. Okay, it's only 10%. 10% of 80 million is a lot of patients. Some of those will start scarring their liver, and the scarring can progress anywhere from mild scarring all the way to cirrhosis, which affects 15% of those with scarring. So this is millions of patients. So if I were to just look at it in a picture form, here's our fatty liver. Fat accumulates in the liver. Inflammation, which can progress to scar tissue or cirrhosis. The majority of patients do not progress beyond this stage. So if I were to do liver biopsies, again, I showed you this earlier, normal liver. This is just fat. I don't know how well this projects in the back, but there's some inflammatory cells there. That's NASH. And then this is actually cirrhosis. You can see these well-formed nodules. The blue is the scar tissue, you can see. So, non-alcoholic fatty liver disease can take a patient all the way from a normal liver to cirrhosis. So what are the major causes of non-alcoholic fatty liver disease? Well, obesity. Obesity here is defined as a body mass index greater than 30. And some studies have put the frequency, how many patients with a body mass index over 30 have non-alcoholic fatty liver disease. Some of the studies, it's approaching 100%. The number we typically quote is 50%. 50%. What about if you're diabetic? probably approaching 50%. And elevated triglycerides, not cholesterol, it's triglycerides. You can see that's all over the place, so we tend to quote 50%. Typically, as your weight goes up, you develop diabetes and triglyceride problems. So they kind of all go hand in hand. So these are the three major risk factors. Now, if I were to walk through the halls of this hospital, how many patients at St. Agnes have a body mass index over 30, type 2 diabetes, or elevated triglycerides? I would argue a large percentage. That's why I'm convinced that this is the #1 disease in this hospital. And I'm not picking on this hospital, because it's at our hospital to every hospital pretty much in the U.S. So how did we get here? How did we get here? Well, as we evolved into where we frequently find our patient population now. It's, you know, everybody has to have more. So the burger, the fries, and how that's changed over time. We have to wash it down with something. Maybe a snack. And then we relax and go to the movies. So we simply have become a culture where more is accepted as better. So what has happened as a result? I don't know how familiar all of you are with these maps. This is data from the CDC. And what you're looking at, so the guide is on the bottom. And this is patients with a body mass index over 30. So the CDC wrote to all the state health departments and said, what percentage of your population, Wisconsin, has a body mass index over 30? And in 1990, Wisconsin was blue, so that is in the 10 to 14 range. And then you can see by 2000, you know, there were states 20 to 24. By 2011, it was yellow. That's down here. Yellow is 25 to 30%. And now we got some, we have some darker red that are over 30%. By far the healthiest state is Colorado, by the way, by far. And they've been the one state that seems to have, to a certain degree, avoided this epidemic. So our patients have simply gotten bigger over time. And it's led to this. This is not something unique to our country, but it is worse in the United States. And you can see that relative to other parts of the world, we struggle with weight. And of course that leads to multiple complications. And yes, today we're talking about fatty liver, but all of these things are complications of increasing body mass index. So let's take a step back. Initially, it was felt that this was related to weight. So what's the relationship to weight? So here we have the body mass index. Men and women, the odds ratio. Obviously, as the odds ratio goes up, the higher risk for developing that condition. And you can see the body mass index, the perfect body mass index, the Centers for Disease Control will say it's between 20 and 25. So, if you're between 25 and 29.9, you're considered overweight. Sometimes we forget this, but a large percentage of our population actually falls into this category. And you can see that if you fall into that 25 to 29, the odds ratio for men is 2.12, for women it's 2.07. So it's not just a disease affecting women. If you're 30 to 34, you're considered obese. Notice that men actually have a greater risk of developing this. And of course, if you're over 40, that's considered morbidly obese. And you can see the odds ratio also higher for men. So clearly we can say that this is not a disorder that affects women only, which was one of the original ways it was described, remember, by Dr. Ludwig back in the 80s. So clearly there is a relationship with weight, whether you're male or female. But I take care of pediatric patients. Non-alcoholic fatty liver disease is the most common pediatric problem. And here's the prevalence, and you can see as our children and adolescents age, the prevalence increases, just like with adults, boys more than girls, and just like with adults, Hispanics tend to have a greater prevalence, and African Americans tend to have lower numbers. So I actually on Friday mornings have a pediatric clinic. And I will tell you that 90% of the patients that I see fall into one of two categories. They're either non-alcoholic fatty liver disease or hepatitis B children that have been adopted, typically from Asian countries. But non-alcoholic fatty liver disease is by far the #1 pediatric liver problem that I see. So is it just weight? Absolutely not, because you can see that lean patients also have a chance of developing fatty liver, including the more aggressive form. Is it as high as obese patients? No. But clearly, weight plays a role, but there has to be something else besides weight here that's playing a role. So this is the same data, but now I'm talking about diabetes, type 2 diabetes. And you can see 1990, here's again our guide. So Wisconsin back then was 4 to 6%, still in 95, 4 to 6%, supposedly it's still 4 to 6%, but look at some of these other states. There's no red here. Red means 8 to 10% of your population is diabetic, and then yellow, Florida, Alabama, over 10%. And to a certain degree, that mirrors the weight. As the weight goes up, it's not unusual to develop type 2 diabetes. So, weight plays a role, diabetes plays a role. What about the lipids? It's the triglycerides. If you have a triglyceride level over 300, your odds ratio is 3. If you have a low HDL, then that also contributes. So the big 3 risk factors are weight, diabetes, and hyperlipidemia. Do you need all 3? Absolutely not. You only need one of those. Are there other things, by the way, that could give fatty liver? Absolutely. You know, we could have a whole talk about alcohol. Certain medications that we give our patients. So I take care of transplant patients. I have to give them prednisone. And prednisone has been known for a long time to cause fatty liver. So it is not just those 3 risk factors. So, what is the patient going to complain of? Well, the majority have no symptoms. This is not a disease that is going to knock you on your rear. It's not like an acute hepatitis where over the last week I've just been so run down. It doesn't do that. It is a disease that causes damage typically over decades. When patients do have problems or symptoms, the right upper quadrant pain is by far the most common. Is there a correlation between the severity of the liver disease and right upper quadrant pain? No. Is there much we can do with that right upper quadrant pain? Typically, no. We're hesitant to give patients pain medications for obvious reasons. Patients may complain of fatigue, malaise. On exam, they'll have hepatomegaly or an enlarged liver. And what we're finding out is that more and more patients are actually presenting with the advanced form. And I would say probably 50% of the patients that I see with non-alcoholic fatty liver disease, they present when they have a complication of cirrhosis. They have a variceal bleed, they become encephalopathic, they develop ascites. So these are clearly complications of a disease that has been present for decades. What about laboratory values? Well, it's the AST and ALT. Those are the two key labs. With more advanced disease, your albumin starts going up, you develop a coagulopathy, your INR starts, so albumin comes down, INR goes up, you may develop jaundice. It's the AST and ALT. Those are the key labs. If you have a very high alkaline phosphatase, you should be looking for other things. Because fatty liver does not impact on the bile ducts. It's the AST and ALT. In fact, it is the most common cause of AST and ALT elevation in this country. And if you have a patient that you see in your clinic or in your practice that has an elevated AST and ALT, and you eliminate a few other simple diseases, you can say with 70% certainty, here is the cause of these elevated liver tests. It's non-alcoholic fatty liver disease. Remember, there is no blood test for non-alcoholic fatty liver disease. So we still consider it a diagnosis of exclusion. You have to eliminate other things. But if I have an elevated AST-ALT and my patient is obese and I eliminate a few other common disorders, I'm at 90% diagnosis. So it is not that difficult to diagnose these patients. It is not that difficult. Sometimes our radiology colleagues will call us, hey, your patient has fatty liver. And it's very easy because normal liver and liver lights up. And the problem with this is you cannot say whether this patient has the simple steatosis, and those patients tend to do well, versus the more aggressive NASH. I see a lot of patients with a CAT scan. Almost everybody who goes to the emergency room for whatever reason ends up with a CAT scan. And many of them, totally unrelated to why they went to the emergency room, are diagnosed with fatty liver. And the key here is the spleen. The spleen. Normal spleen, normal liver, normal spleen, fatty liver. So it is not, again, that difficult to diagnose fatty liver. The next question, though, becomes, what is the severity? So how does all this happen? Well, we've already talked about the fact that as a society we eat too much. We've become more sedentary. You know, we blame our parents. You know, this leads to obesity, hypertension, hyperlipidemia, metabolic syndrome. That causes insulin resistance. Insulin resistance takes a normal liver and makes it fatty. This is the part that we have less understanding of. This third hit. So the first hit was up here. This is the second hit. The third hit is this oxidative stress that takes a fatty liver and makes it fatty with inflammation. And if you have fat with inflammation, then you are at risk for cirrhosis. So when we talk about therapy, towards the end of the presentation, we will talk about the three areas we can intervene in. Here, here, or here. So, you have a patient with elevated ALT or AST, you suspect fatty liver. Remember, it's a diagnosis of exclusion. What are we supposed to do to rule out other potential etiologies? Well, obviously alcohol. How much alcohol can somebody consume before it becomes alcoholic liver disease versus non-alcoholic? So, believe it or not, 6 drinks per day, which to me is excessive. So if we believe the current guidelines that are used, if I have 5 beers a day and have fatty liver, they're saying that's not enough to cause alcoholic fatty liver, which is clearly wrong. So I expect those criteria to be changed over time. Viral serologies, hepatitis B and C. Remember, hepatitis A causes an acute hepatitis, it's never chronic. Iron studies, iron, ferritin, transferrin. Wilson's disease, particularly if it's a younger patient. Everyone gets this ceruloplasmin, although the best test for Wilson's disease is a 24-hour urine for copper, and the copper should be through the roof. And then we check some simple autoimmune markers, anti-nuclear antibody, anti-smooth muscle, And I always, for completeness, check an alpha-1 antitrypsin level. So if you were to send a patient to me with elevated liver tests, this is my chronic liver disease workup. This is what I do. And now I'm fairly confident that I have a patient with non-alcoholic fatty liver disease. Now, how severe is it? That's your next question. And we've always done liver biopsies. Hepatologists, we like to do liver biopsies because, well, they're not on us, it's on our patients. So my arguments for doing a liver biopsy are following. I can exclude other causes of liver disease. Yeah, I could probably do that with the simple blood test I already mentioned. The second point is key, though. It distinguishes steatosis from NASH. Steatosis will cause fat, it will cause elevated liver tests, but never causes scarring. Never causes scarring. Your patient will never die from steatosis. They'll die from heart disease because they're overweight, diabetic, and have elevated lipids. In fact, I should mention that the #1 cause of death in patients with non-alcoholic fatty liver disease is cardiac disease for obvious reasons. But a biopsy would help you with that. And patients appropriately being anxious, I can, with one liver biopsy, I can pretty much tell you how things are going to look for the next 10 to 15, 10 to 20 years. And if you allow me to do biopsies every 5 to 6 years, I'll actually plot it out on a curve for you, just like the nephrologist. Here's your creatinine clearance. Here's when you're going to hit dialysis. So, again, that's the argument. Arguments against doing the liver biopsy. Well, generally good prognosis for non-alcoholic fatty liver disease. Yes, for 90% of patients, not for the 10%. I will tell you, by the way, that non-alcoholic fatty liver disease by next year will be the leading indication for liver transplant in the United States, now that we have Hep C therapy. And it is the #1 cause of liver cancer in the United States. So it's not always a good prognosis. For the majority it is. Lack of proven therapy, absolutely. There's no FDA-approved therapy for this condition. And of course, anytime we do any procedure on our patients, we are putting them at risk. And we have to recognize that. Here's my reason why I think a biopsy is important. All of these patients have an AST or ALT 2 times normal. 2 times normal. Simple fact. Hey, I'll be honest, I'll see this patient once, I tell them about lifestyle changes, I plug them into a dietitian, but I probably don't ever need to see this patient again. Will they have elevated AST and ALT? Sure. We're not treating the AST, ALT. What you're concerned about is the scarring, the damage in the liver. And these patients will not progress beyond simple fact. Here, 2 times normal, but they have inflammatory changes, but no scarring. This is a patient I'll follow maybe once a year. And here's a patient, 2 times normal. Not only do they have inflammatory changes, but the blue is scar tissue. They're working their way towards cirrhosis. So I would follow these 3 patients. I would discharge this patient from my clinic. Hey, come back to me every year to 18 months, probably seen twice a year. All have the same liver numbers. How would I know without a biopsy? And the pathologists now are so good that they can actually, this is just looks at the various features, and they have what's called the non-alcoholic fatty liver disease activity score, and they simply add numbers, and they tell you whether this looks like the most aggressive, the score over 5, the score not that important here, less than 2, no evidence, intermediate. Again, you need a liver biopsy for that. This is from the Mayo Clinic. Can we use non-invasive tests? Absolutely. This is magnetic resonance elastography. And basically, no scarring in the liver. This is a 1, stage 2, stage 3 bridging, and this is cirrhosis. non-invasive. So I suspect in the future, many hospitals will have this. We're fortunate enough we have this. It's rather expensive. But we now have a way to avoid a liver biopsy and still be able to quantify the fat and the inflammatory changes. So this patient, I would not follow in my clinic. This person could be heading towards liver transplant. Again, a non-invasive way. We also have what's called the FibroScan machine, and I suspect you have that here. And what this does is it's portable, so we actually have in our clinic. Patient has to be fasting 3 hours. There's no radiation. We do it right in the clinic, and basically it bounces sound waves off the liver. And normally the liver is like jello, so the sound waves hit the liver and the liver absorbs them and the sound waves come back slowly. A stiff liver, because they're scarring, the sound waves will bounce back quicker. It's like bouncing off the wall. And we can actually see, it gives us a score, and the chance of that patient having more advanced disease. So if I have a patient with fatty liver and they have a FibroScan score of 14, that is cirrhosis. All of this red is cirrhosis. And you can see you can do for alcohol, for other diseases, hepatitis C, Hep C by itself, and with HIV, hepatitis B. 95% of my liver biopsies have gone away because now I have a non-invasive way to get information. This is, of course, with the understanding that I already have a diagnosis. Now I'm determining the severity of it. You can actually download this. There's a nice calculator. It's called the QX calculator. It's got every formula in the world. It will solve all of your problems. I made up a patient here, a 50-year-old with a body mass index of 35. Do they have diabetes or pre-diabetes? I checked yes. I gave an AST of 50, ALT of 50. I gave him a platelet count of 150,000. I gave him a normal albumin. It's a score of 2. What does that mean? A score of 2 means they are at stage 3 to 4. A score less than minus 1.455 is 0 to 2. Remember, when we're talking about scarring, we're going from 0 to 4. 0 is no scarring, 4 is cirrhosis. So this patient, I can say with fairly high certainty, likely has cirrhosis. To 100% confirm it, you need a biopsy. But I'm a believer enough in this simple calculation that that is a patient that I'm going to pay more attention to. So simply plugging in some patient characteristics and labs. Let's turn our attention to treatment. This has always been, okay, we've essentially cured Hep C. What are we doing for fatty liver? Why should we bother? There's nothing you can do. So we've come a long way. I don't know where I got this slide. Fat, the enemy of the food in your life. Now you can banish fat with sanitized tapeworms. No diet, no baths, no exercise. So we've come a long way. So, step 1. We're getting too big. Step 2 is the insulin resistance, and then step 3 is the oxidative stress. Let's start with the first one. Does weight loss work? Absolutely. And the data shows that versus controls, those who lose weight, the non-alcoholic fatty liver disease activity score goes down. There's improvement. You can see that. How much weight does the patient need to lose? The magic number appears to be 10% of their body weight. So if I weigh 200 pounds and I have non-alcoholic fatty liver disease, the magic number for me would be 20 pounds over 6 to 12 months. And I actually take my time with patients on this. I say, you know, your weight didn't get to this point overnight. Do not do these diets you see on TV. I've lost 10 pounds and 3 inches in the first week, because by week 2 you will be so exhausted you can't do it. And I say, lose 1 to 2 pounds a month. And they said, that's it, 1 to 2 pounds a month. So when I see you in 6 months, you should be down 10 to 12 pounds, in that range. And it's realistic. It's realistic. So we know that weight works, weight reduction. And these are 3 older studies, but Hickman here, diet plus exercise, 31 patients for 15 months. Did they improve the liver test? Absolutely. Did they improve the liver biopsy? They didn't assess that. Dixon did gastric band, 36 patients, 25 months, improved the liver numbers, and the liver biopsy improved. Harrison did patients orlistat, inhibits fat malabsorption or fat absorption, small number of patients, but also improved liver test and histology. So I think we can conclude that weight loss is good, 10%. This, to me, is a very impressive study. It's an old study from 2004. And what they did here is they had 36 patients with fatty liver. 23 had NASH, the most aggressive form of fatty liver. And they underwent bariatric surgery. And their mean weight loss at 25 months was 34 kilos or 51% of their weight. Now that is significant weight loss. And then they restaged them all. What did they find? Only 4 of the 23 had NASH. So our patients that are undergoing bariatric surgery are not just getting the cardiac improvements and the reduction of the stress on their joints, it's actually helping their fatty liver. So weight loss. What about insulin resistance? Insulin resistance, that's step 2. So these are studies that were done using various agents, you can see, in patients who were not diabetic. Let me repeat that. They were not diabetic. 36 patients, treated them 6 months with metformin, improved the liver test and histology. Small number of patients, 3 to 6 months, yes. Pioglitazone with vitamin E, I'll talk more about that in a second. 20 patients, 12 months, yes. So treating insulin resistance, even in those that are not formally labeled as diabetics, actually helps. Now, obviously, there's always a concern utilizing a medication when you don't, quote, have a good reason. Why should we be using these diabetic medications in individuals who are not formally diabetic, depending on what criteria you use? This small study here looked at pioglitazone and vitamin E, and there was a lot of interest, so they expanded. And this was in the New England Journal of Medicine almost a decade ago. 247 adults without diabetes were treated for 96 weeks, so almost 2 years. 80 patients got the pioglitazone, 84 got vitamin E. Vitamin E is an antioxidant. Remember that third hit, the oxidative stress, vitamin E. 83 patients received placebo. What was the most effective? It was vitamin E. A close second was the pioglitazone. Now, vitamin E, there's concerns about prostate abnormalities. Vitamin E we utilize it on patients who have NASH, who do not have cirrhosis, and who do not have diabetes. There's actually no data on those who have diabetes or cirrhosis. But if they simply have NASH, and you can exclude those other two, vitamin E, 800 international units is actually it's over the counter, and it's quite effective. What are some newer therapies? There's these glucagon-like peptides, and you can see that they have quite a few effects. They decrease appetite, cardioprotection, decrease glucose production, insulin sensitivity, increases insulin biosynthesis. So here's one of them. So Victoza is the trade name for this medication. Just concentrate on here, this middle one. This is your ALT. controls and patients treated with this medication. And here is the GGT. The GGT is not as valuable, that's why I never mentioned. Other good things, weight loss, hemoglobin A1C obviously improves. It has almost no effect on HDL and on blood pressure. You can't read it from the back. So this is a medication that appears to be effective, but again, not approved for this. What about these acetyl-CoA carboxylase inhibitors? Acetyl-CoA is a necessary, I won't bore you with all the biochemistry, but it is an essential step in the formation of fatty acids, adipose tissue. So anything we can do to block that is good. So if we block acetyl-CoA to these acetyl-CoA carboxylase inhibitors, it actually increases fatty acid oxidation, reduces fatty acid synthesis. That's good. We want that. So here what they did is they gave higher dose, intermediate dose, and placebo. And you can see this is using that fancy MRI I showed you earlier with the fat. You can see that there was, with the higher dose, a 30% reduction in fat. The intermediate, about 12, placebo, about 10. How many had more than 30% reduction? Nearly half. So this medication appears to be able to decrease the amount of fat in the liver by inhibiting that T-step. Again, all very early stage. It doesn't even have a name, just numbers. Beta-cholic acid is actually something that reduces the concentration of bile acids in liver cells. It's actually approved for primary biliary cholangitis, formerly known as primary biliary cirrhosis. And somebody said, well, let's try it in fatty liver. And here's what happens to the ALT, and here's what happens to the AST. So this is an approved therapy for primary biliary cholangitis, but not for fatty liver. Can we actually take the scar tissue and make it go away? The answer is yes. Without going into too much detail, here they combine these two agents, apoptosis signal regulating kinase and lysyl oxidase-like molecule. The key here is, and I know it's blurry because I cut and pasted this, but green is improvement, meaning scar tissue is going away. The more red, that's worse. So with this combination therapy, 42% of patients had a reduction in their fibrosis, the scar tissue. Only a small number had progression. So, yes, there is currently nothing that is approved, but there is a lot of interest in this because whoever finally does get something approved from a pharmaceutical standpoint is going to make a lot of money. And this is what drove a lot of the hepatitis C research. This is very complicated, and we've only touched on a few of these, but all of these come into play. So, in summary, non-alcoholic fatty liver disease is the most common liver condition that you will encounter. I would say it's the most common type of patient you have. It's the number one thing responsible for AST and ALT elevation. It is very important to differentiate from simple steatosis, where your patients will die of heart disease, from NASH, your patients will die of liver disease and heart disease with that condition. Up to now, it's only been the biopsy that's allowed us to differentiate. Now we have a few other things. We have elastography. We have all those fancy calculations. It is important to correct the underlying causes. Encourage weight loss. What's the magic number? 10%. By the way, statins are not contraindicated. If anything, you want to give these patients statins, even if their liver tests are abnormal. Statins are beneficial here. There's currently no FDA-approved therapy. I've mentioned that throughout the discussion. However, I think within the next 5 years, you're going to see a handful of medications because this is such a common problem that impacts our lives. large percentage of our population. And there's a lot of research going on. So I believe that's my last one. So I'm going to stop here. I believe we have about at least 5 minutes for questions and answers. Question? Anything I can answer for? Yes?
So in December of last year, the New England Journal of Medicine had a nice review on this subject, and the authors, among lifestyle interventions, listed black coffee as potentially beneficial. Could you comment on that?
Yeah, so coffee is actually very good for the liver. It actually decreases inflammation, and there's actually a large amount of data now that individuals who consume, I think it was 2 to 3 cups a day, actually have a marked decrease in liver cancer. A lot of us were skeptical, myself included, but when we go to our national and international liver meetings, now there's tons of data. So yes, coffee is hepatoprotective. I've not seen much data of treating specific conditions. So, for example, if I had Hep C, do I use antiviral therapy with coffee? But if you do nothing else and your patient's a coffee drinker, you should not discourage them from consuming coffee. Absolutely. Good point. Yes?
What causes the inflammatory process?
So what causes the inflammatory? Why do some patients not progress beyond the steatosis? That is a good question. We've not been able to answer that. When I say we, obviously the researchers. I'm not a researcher, but that is a key question. Up to now, we focus on differentiating those two groups. Remember, if you do nothing else, 90% of your patients are going to do just fine. It's that 10%. And again, we had the biopsies in the past, but now we have these other markers. Why some don't progress? Don't know. I will tell you that if I do a biopsy and they've not progressed, we don't typically say, let's re-biopsy them in 3 years, see if they've progressed. The understanding, and it may be flawed logic, the understanding is that if there's no inflammatory changes there, you're done. So. Yes?
Your body goes to simple fatty liver, not any alcohol at all.
So my standard line for alcohol use is never more than social use, regardless of the cause. So I think in reality we could probably be a little more liberal in those patients. Do not chase necessarily, once you have evaluated these patients, do not chase that AST and ALT. Because I think we put too much attention on those patients with simple steatosis. I would say work on them with their cardiac risk factors, because that's much more, they tend to struggle with their weight, diabetes, typically they're hypertensive. This is just a bad recipe. You throw in a little family history. So, yes?
When do your patients eat last?
What's that?
When do your patients eat last?
When do my patients eat last?
Yeah. I bet if you go back to the clinic and ask them, they'll all say they have a bowl of cereal at night. Because I tell people, look, if you quit eating your bedtime bowl of cereal, you stop eating by 5, and make your last meal low carb, I've had many patients who let LFTs normalize. And normalizing is not what I'm trying, because when we load up our belly at night, that's when our metabolism is not ready to handle this, which is where acid.
And there's some logic to that. I will tell you that, speaking for myself, but I suspect also the majority physician, we're advising our patients on nutrition and diet, but we're not very good at it. And I'll put myself in that category. I'm spoiled because just down the hall I have the metabolic clinic, the endocrine folks. And every patient that I see with fatty liver, whether they have the simple steatosis or the NASH, I send them to that clinic at least once. They may think they're doing all the right things, but they're not. And sometimes it just takes somebody knowledgeable to point that out to them. So, absolutely. I also have patients, I send them to the metabolic clinic, they come back and they weigh more 6 months later. We still have to work with those patients and try to encourage them. But weight loss is not easy. We say, oh, just go and lose 1 to 2 pounds a month. For many, that is not easy, and we should not minimize the fact that they're trying but not succeeding. It's like asking somebody who's been a lifetime smoker to stop smoking. It is not easy. It's not easy. Well, thank you very much for your attention.